Hello. For those of you that do not know me, my name is Diana Warren and I am a registered adult and neonatal nurse, infant feeding specialist, board certified lactation consultant, baby massage and yoga instructor and a tongue tie practitioner. Today I want to talk to you about what you may like to consider before attending a tongue tie consultation. There is a lot of information on the slides, but the beauty of a recording is that you can repeat all of the bits that you need to. Throughout the presentation, I refer to my own practice, how my service works, and what you can expect from me. However, should you be viewing this presentation out of interest, but with you to see another practitioner, please refer to their guidance and support, as all services support infants and their families in different ways. And so, for the formal bits, please be advised that all work provided in this presentation is protected by my copyright and it is illegal to share, copy or repurpose the materials for your own commercial use or with others. You are entitled to use these materials for your own personal use. This presentation will not teach you how to assess nor divide a restrictive tongue tie. So formal definitions then. So NICE guidelines of 2005 suggest that ankyloglossia is a congenital anomaly characterised by an abnormally short lingual frenulum. This is where the tip of the tongue cannot be protruded beyond the lower incisor teeth. It varies in degree from a mild form from which the tongue is only bound by a thin mucous membrane to a severe form in which the tongue is completely fused to the floor of the mouth. Then we have a frenulotomy procedure. And this is the procedure term that is used for excising the frenulum, such as the excision of the lingual frenulum from its attachment to the mucoperisteal covering to the alveolar process to correct the ankyloglossia. The National Institute of Clinical Excellence back in 2005 suggested that there were no major safety concerns about division of ankyloglossia, but acknowledged that there was limited evidence at the time to suggest that this procedure could improve breastfeeding. So what does all this mean? Well, a tongue tie is a problem that occurs in infants who have a tight piece of membrane between the underside of the tongue and the floor of their mouth. The medical terminology for it is ankyloglossia, and the piece of membrane joining the tongue to the base of the mouth is known as the lingual frenulum. It may affect the infant's feeding ability, making it hard for them to attach properly to their mother's breast or an artificial teat. Normally, the tongue is attached to the base of the mouth with a piece of membrane known as the lingual frenulum. However, in infants with a restrictive tongue tie, this frenulum is unusually short or tight, inhibiting the tongue's movement. This in turn prevents the infant from feeding properly and may also cause problems for the feeding adult. To breast or chest feed successfully, the infant needs to latch onto the mammary tissue and draw in the nipple through a vacuum. The infant's tongue needs to cover the lower gum so that the nipple is protected from any damage or injury. Infants with a restrictive tongue tie are not able to open their mouths wide enough to latch onto a breast or form a seal on a teat dummy pacifier properly. Breastfed infants do tend to slide off the breast and chomp onto the nipple with their gums, so a shallow latch. This can be painful and the parent's nipples can become sore, cracked or bleeding. Some infants feeding frequently but inefficiently, and then they tire really quickly, but then they soon become hungry and want to feed again. In some cases, these feeding difficulties mean that the infant fails to gain much weight, but in other cases they gain weight due to the frequency of feeds rather than the inefficiency. It is not specific to chest or breastfeeding. It affects all methods of feeding. They just display different symptoms. Assessing for a restrictive tongue tie. Tongue tie assessment is not part of routine medical training for doctors, midwives, health visitors or allied healthcare professionals. It is important that they differentiate between their opinion and evidence-based fact. Many healthcare professionals in our local area are experienced and they do receive training and guidance of when to suspect a tongue tie restriction, but not necessarily diagnose one. Should you choose a private practitioner, do research into their background and reputation and their own experience, including how they may support you after the procedure. By law, they should also be a registered healthcare professional and be regulated by their country's governing body. Tongue-tie division is not to be substituted for poor infant feeding support. It is paramount that your practitioner is qualified in extensive infant feeding support. Gold standard for this is an IBCLC. Quality infant feeding support provided by a highly skilled and experienced practitioner is overriding to the success of this procedure. So a little bit of a background into tongue-tie. We know that tongue-tie has been a controversial issue since the 1700s. There are biblical references to it, and just a couple of centuries ago, midwives would grow their little fingernail and excise the frenulum at birth, and predating that, even midwives would advocate stretches of a frenulum itself. So even then they recognised that a tight frenulum could pose a feeding issue. But after the Second World War, it was decided that that was actually a little bit unhygienic, and formula companies quite heavily promoted their own formula as an alternative method of feeding. The problem being is that it was just that, an alternative method of feeding. It didn't address the root cause, and certainly we know now that tongue-tie restriction can also affect feeding on the bottle. In 2005, NICE brought out recommendations acknowledging that frenulotomy is recommended for those with a tongue-tie restriction, but needs to be done by somebody that is professionally trained to do so. And then in 2019, CQC for England regulations indicated that it was a criminal offence to provide a division without being registered with them, and that all providers of the service need to be registered with them, as a frenulotomy is considered a regulated surgical procedure. It is normal anatomy to have a visible frenulum. Only if there is a restriction impacting on infant feeding ability should a division be considered. Research indicates that as many as 1 in 10 people have a restrictive frenulum, but that research did only look at anterior restrictions. It's believed that if you were to include posterior restrictions, which can be just as problematic, this could be as common as 1 in every 4. A restriction can be classified by type or percentage, but it is not an indication or reflection on the impact of the symptoms. It's not about what it looks like, it's about what it can and can't do. Some providers do suggest that it is slightly more common in males, and current studies are looking into causes such as environmental factors, for example folic acid absorption and gene mutation. Some also believe it can be a hereditary anomaly. Research is ongoing. Messner acknowledges that during the embryologic stages of development, the frenulum is in the midline of the mouth, guiding oral structures which recede through a process called apoptosis at around the 8 to 10 week mark of pregnancy. Catherine Watson-Jenner, later in 2008, explains that if the lingual frenulum is inelastic, too short, has failed to regress and extends along the underside of the tongue, or is placed too close to the gum ridge itself, tongue function will be restricted. There are lots of theories of what a tongue-tie restriction may impact upon. A division in infancy can only be performed if there is a tongue function deficit impacting on infant feeding, as other implications are not known for the ages of the infants that we can treat. Suggested issues may include breast and chest feeding, bottle feeding, breathing, disordered sleeping, facial growth and development, dental implications, speech, starting solid foods may be delayed or struggles with, and posture. It is important to note the symptoms of how a tongue-tie can impact breast and chest feeding. As I said previously, it is important that you see somebody who is skilled in infant feeding, as these symptoms can be accountable to other causes too, and they would need ruling out before considering any surgical procedure. Such symptoms may include being frustrated or angry to feed, a shallow latch, being unable to sustain or slipping off the breast, nipple distortion, vasospasm, nipple and or deep breast pain, poor breast drainage or engorgement, thrush to mum and baby, blocked ducts, blebs or mastitis, dribbling or spillage of milk during an active feed, feeding aversion, weight issues, now this can be a rapid gain or even a maintenance or loss, unsatisfied after a feed and snacking, sucking blisters or two-tone lips, uncoordinated rhythm of suck, so the transfer of the milk, quick forceful letdown, oversupply or even an undersupply, gagging or retching to a feed, or tires to feed. But generally speaking, physically, this tongue tie now affects both members of the feeding dyad, so the mum and the baby are affected. As we know, a tongue tie restriction isn't exclusive to breastfeeding. It can affect bottle feeding infants as well, and these symptoms include being unable to control the flow of the milk, dribbling or spillage of milk during an active feed, tiring to feed, being frustrated or angry to feed, thrush, clicking noises, tongue thrust or teat rejection, feeding aversion, vomiting, shallow latch onto the teat, trap wind or colic, taking large volume feeds or snacking smaller volume feeds, getting sucking blisters or two-tone lips, crushing the teat with the gums, piston action onto the teat to extract the milk, or an uncoordinated rhythm of suck. So a few notes on the assessment process itself. Different practitioners do utilise different tools just to categorise the appearance and the function motility of the tongue. It's not really about the type though. The type itself does not indicate the treatment required. It just categorises using a visual method, more so that the practitioner is aware of the position and the placement of the lingual frenulum and for documentation purposes. Diagnosis is not centred around what the frenulum looks like, which in itself is normal anatomical appearance. It's about what the tongue motility can or can't do as a result of the frenulum being restrictive. It's not about what it looks like, it's about what it can do. Position is also not a reflection on severity. This can only be assessed by a highly skilled professional trained in both infant feeding and tongue tie assessment. Assessment is usually carried out with the baby on a flat surface, such as a table or a couch. It involves observing how the baby uses their tongue. Assessment for tongue tie requires training and skill and involves placing a finger in the baby's mouth. It cannot be done just by taking a look.
Right, so I'm going to talk you through how to assess for tongue tie now. So what I'm doing here with this little baby is I'm stroking his bottom lip and the tip of his tongue to try to encourage him to poke his tongue out over his bottom lip. You can see there that his tongue is coming slightly forward just to the gum, but not actually out and over his bottom lip. Then I go on to assess lateralization. So I'm running my finger around his bottom gum to try and encourage him to follow my finger with the tip of his tongue, and you can see he is doing that there. It's a little restricted. Ideally the tongue tip should go right round to where the wisdom teeth will come through. Then we move swiftly on to a suck assessment. And here I'm feeling for where the tongue is. Is the tongue actually cushioning the gum, or is it slipping behind the gum or sitting behind the gum? If it slips behind, the baby will not be very secure on the breast. You could just see a little gag there. There's the gag reflex. This baby actually had quite a high palate, and babies with high palates often do have quite a sensitive gag reflex. Obviously, if the tongue is not coming forward over the gum, not only will the baby not be very secure at the breast, but that gum is going to rub mum's nipple and be quite uncomfortable and make feeding quite painful for her. So now I'm going to sweep under the tongue to see if I can feel a tight frenulum. And invariably when you do that on a baby that's got a tongue tie, they do cry because the frenulum is quite tight and it just feels quite uncomfortable when you push against that tension and that tight frenulum. And then you can see with the crying, that's a good time to assess the elevation. And that little baby there didn't lift his tongue very high at all. I'm now going to show mum the frenulum. so she can see what I'm talking about, and you can just about see that there. So I usually do that at the very last.
The tongue and the palate combined work together to make feeding ability efficient. In order to breastfeed, an infant needs to have an ability to extend their tongue over their bottom lip and draw in breast tissue using a vacuum. The tongue then uses peristalsis to massage the breast to remove the milk using the negative pressure. The soft palate muscles lift to close off nasal breathing, allowing the milk to be drawn through, creating a bolus to stimulate a swallow, thus transferring the milk. It is common for those with a tongue-tie restriction to also have a high arch palate. Symptoms of having a high arch palate may include daily hiccups, daily sneezing, clicking noises, grunting or noisy feedings, snuffly or congestion noises, trap wind or colic, reflux or silent reflux, audible heavy breathing at rest, open mouth breathing, or a sensitive gag reflex. So just to reiterate, the tongue-tie procedure itself is not a magic wand. It will not resolve all of the feeding issues identified without highly skilled infant feeding support, both before and after any surgical release. This can include support with positioning, suck training, supply stimulation, paced feeding, pain management and healing, feeding plans to support infant weight whilst protecting maternal supply, amongst many other potential needs. An IBCLC is the gold standard level of infant feeding support for both breast and formula-fed infants. They are board-certified professionals that have strict regulatory guidelines to follow in order to keep their knowledge base current and their registration valid. By law, your tongue-tie practitioner has to be registered with a healthcare regulator, plus their professional regulatory bodies too. There are different methods used to provide a surgical release of a tongue tie. The most common of which in the UK is a scissor divide, and this is where the baby is swaddled and on a flat surface, the tongue is lifted by the forefinger of the practitioner, and then a pair of special sterile surgical scissors is used to excise the membrane to release the restriction. But other methods may include a laser, may include diathermy or electrocautery, or even a scalpel or a blade by a specialist surgeon. As with any surgical procedure, there are risks to be considered before consenting to the release, all of which should be discussed in a greater depth by your practitioner at your appointment. These include inadvertent injury to surrounding oral structures, wound infection, reformation risk, an incomplete release, pain. As with anything in medicine, there are no guarantees that the procedure would be 100% successful. Blood loss and additional unknown risks that we're just not aware of at the moment. Blood loss and bleeding is always a concern for any parent. There are national guidelines in place to follow should blood loss be of a concern. In a survey by the Association of Tongue-Tie Practitioners in 2023, 6 out of 9,285 received additional medical attention for bleeding, only one of whom required intervention to help stop the bleeding. After the procedure, the wound may visually resemble a mouth ulcer with a creamy, milky colour within a couple of days. This may be a slightly different colour if your baby is jaundiced, for example. It may take like a yellowy tinge to it. But as this heals, it recedes and disperses and dissolves into the body, at which point it's no longer visible, and that can take around 7 to 10 days. A residual frenulum then is likely to appear after this point. It is considered normal unless it is also restrictive. Should you have any concerns, questions or queries about how the wound is healing, your chosen practitioner is best placed to address these. Ongoing support is crucial to the healing and learning process, to your unique feeding journey, and also your own mental health. Know how to contact your practitioner should you need to. Considering wound care now. The wound created may take up to 10 days to heal. My advice would be not to touch, check, or attempt to even feel the wound directly. Assessment during the healing process could reveal residual frenulum, but once the wound is healed, it does generally soften and recedes back again. Interfering with an open healing wound can cause scarring, pain, rebleed, infection, or even an oral aversion. The wound of a jaundiced infant may look bright yellow or orange or any colour of the rainbow really in appearance. It is normal and expected, as it is the red cells coming to the surface of the wound bed. It's not a sign of infection in the absence of any high temperature and does not seem to take any longer to heal. In some areas worldwide, disruptive wound management is recommended, and this is quite popular at the moment, showing on TikTok and Insta Reels. This is where parents are encouraged to reopen, lift or stretch an open wound to prevent reattachment or reformation multiple times a day. Evidence suggests that it does not lessen nor heighten the risk, but incidents of infection, rebleeding, scarring, and oral aversion and pain are all factors to consider. These are sometimes termed as wound massage, tongue tie exercises, or tongue lifts. They're not the same as tongue function exercises, so just to be mindful of that. The ATP do have a position statement on disruptive wound management, which can be accessed directly on their website. If there are any concerns with the wound itself, the parents are encouraged to discuss this with their original practitioner or a doctor. The aim of tongue strengthening exercises and facial tension release is to improve oral function and tongue tone through keeping the tongue mobile and relaxing any further potential tensions. They do not involve touching or stretching the wound. They are not mandatory. They are not intrusive and should not be painful. Breastfeeding provides the best physiotherapy as it involves all areas of tongue function working simultaneously in harmony. All practitioners have their own protocol advising when, where, and how, if necessary. Your chosen practitioner will be able to advise. Tongue function exercises are commonly confused with disruptive wound management. Disruptive wound management, sometimes known as tongue tie exercises, tongue lifts, or even wound massage, is a controversial topic, and many tongue tie practitioners do not advocate these, particularly in the UK. Tongue function exercises, on the other hand, allows the caregiver to work on tongue motility. The tongue itself is a collection of muscles, and there will be an element of muscle weakness. There are some specific exercises that can help work on the weakened areas, and your tongue tie practitioner will be able to suggest to you which would be the most beneficial for your baby. But on the whole, breastfeeding is the only method that works all areas of tongue function and is the best exercise for the tongue. Manual therapies are also beneficial both before and after a tongue tie release to help address any tensions that may have been created from the restriction itself in your infant, but also from any birth interventions or traumas, or even during the pregnancy itself. Types of manual therapies include osteopathy or cranial osteopathy, chiropractic interventions, oral facial myofunctional therapy, suck training, baby massage, physiotherapy, or cranial sacral therapy. Do research into your chosen therapist, looking at recommendations and reviews before booking. A little note on lip tie, which is an anomaly that you may or may not have heard of, but is medically termed as the labial frenulum. Lip tie diagnosis and division is another controversial topic in the UK. In some countries, practitioners do divide that too, alongside a tongue tie, but current research does suggest that this isn't necessary. It is also worth mentioning that many perceived lip tie problems are confused with tongue tie restriction symptoms, and once tongue function reaches optimal motility, the symptoms of the perceived lip tie alleviate. You may find this article on my blog helpful, and I'll bob these onto my website separately too, so you can click on the link. Lip ties may cause dental implications, and so regular dental visits as routine are suggested. A labial lip tie is normal anatomy. They do tend to recede as one grows. The best profession to get further information on this is the infant's dentist. The Association of Tongue Tie Practitioners has a position statement on lip ties too, but there is no evidence at all to suggest that a lip tie can affect breastfeeding. I'd just like to finish with clarifying some common myths that I hear too frequently. The first is that if your baby can stick their tongue out, they're not tongue-tied. This is false. Protrusion of the tongue is assessed whilst the sucking reflex is stimulated, in the same way that if they were feeding. Protrusion is just one motility function that's assessed. There are another 6 that need to be taken into account. The second is that if your baby's gaining weight, they're not tongue-tied. Again, this is false, because whereas in some cases they do lose weight because they're not efficient at feeding, the majority gain weight because they're inefficient at feeding, so therefore they're feeding more often. So they're feeding little and often and gaining the calories and the sugars and the proteins that way. Cup feeding your baby is a good alternative feeding method. It is a great alternative feeding method for breastfeeding, but it's not the best feeding method for the tongue-tied infant, because babies have to lap up the milk in the same way that a kitten would, and tongue-tied babies very often can't stick their tongue out to protrude it in order to lap up the milk to form a bolus in the same way. Your baby has a slight or severe tongue tie. Again, this is false, on the grounds that these are really quite ambiguous terms, and gives the impression that it should or shouldn't necessitate treatment. Some tongue ties that are posterior in appearance are considered a slight tongue tie, but they can cause just as many feeding problems as an anterior short thick frenulum. Tongue tie babies have speech problems later on in life. Again, some babies would have a speech problem later on in life. Could be as a result of a tie, but it could be other factors too, or even both. It's unclear. Current evidence suggests that some children would have speech problems caused by a tight lingual frenulum, but a definite percentage of these is not yet known and is more to do with the articulation and the pronunciation rather than an impediment itself. And we cannot say yet if this is the case for all tongue-tied infants. Your baby's tongue tie will stretch in time. Again, this is false. The restrictive frenulum is a membrane which is now likened to ligament tissue, and ligaments do not stretch. They remain relative to the tongue as the infant grows and develops. It's more likely that the infant would use their tongue in a compensatory way and learn to live with it. And finally, tongue tie only affects breastfeeding. There's always a bottle. As well-meaning as this term is, everybody has a frenulum. 95% of them are visible, and that's normal anatomy. If it is restrictive though, it affects all methods of feeding. A bottle is just an alternative method of feeding, and symptoms are more manageable, but a restrictive tongue can be the root cause of the problem. The bottle is not going to provide the solution. So to summarise, all methods of feeding are affected by a restriction. An alternative method of feeding will not address the root cause. It is not an instant fix. The tongue is a collection of muscles, and other oral structures may also be tense. Consider body therapy as a combination approach. Do research their experience and look at recommendations. Choose a reputable, experienced and highly skilled tongue-tie practitioner, where able, an IBCLC. Consider what aftercare support you may need or have access to. Is now the right time for you, for your baby too? Familiarise yourself with the risks and ask your practitioner all your questions.